All right. Welcome, everyone. I'm very excited today for a special Ask the Experts that we have, Understanding Your Options, a GYN Q&A on medical menopause management, which is a topic that is very near and dear to myself and Erin as well. We've spoken on it from a nutrition perspective, and we know that it is so important to our community as a whole. So we're very excited to dive in today. But before we even get started, as always with our education events, we do want to take a moment just to thank our wonderful sponsors. Our virtual education events are presented through UFH Connect by West, Merck, and Novartis with support from gold sponsors Pfizer and Daiichi Sankyo, and our supporting sponsor, GSK. And our UFH Connect as a whole would not be possible without them. So we are ever so grateful. If you haven't been to a UFH Connect event before, welcome. We are very happy to have you here. This is our June Ask the Experts, our Q&A style segment. And my name is Aubrey. I'm our culinary nutrition manager here at Unite for Her. We're streaming live over on Facebook. However, this will also be recorded. So if you need to pop in and out for any reason, please know that you'll be able to go back and watch the recording later. And if you're joining live with us on Facebook, feel free to ask any questions in the chat. We'll bring them over here. We'll try to answer as many questions as we can. We do have a big lineup today. And we always like to mention with any of these segments that we can't necessarily answer specific medical advice and questions, but we can certainly help to try to point in the right direction. Before we dive in, I want to mention too that we're going to round out the month of June with one more education event. Next week on Wednesday, June 17th at 5 p.m. Eastern Time, we have our virtual hangout, our summer beauty celebration with Jolene Hart and Rebecca Casciano, talking about summer skincare tips for sweat, for glowing beauty, but also makeup this time of year. To register and view all of our education segments in our education network, you can visit our UFH Connect webpage, uniteforher.org/UFH Connect. Without further ado, I will bring up our special guest today and give her a brief introduction. So I'm very pleased to be here with Dr. Kim Einhorn, who is the founder of the MP Collective, a membership-based gynecology practice dedicated to the care of midlife women with a focus on perimenopause and menopause in Bryn Mawr, Pennsylvania. The practice is the first of its kind in the greater Philadelphia area and is focused on myriad services designed to support women in optimizing their health and longevity. Her approach to care is holistic, evidence-based, and empowering. While each menopause journey is unique, Dr. Einhorn empowers women with the knowledge and tools necessary to thrive during this transformative stage of life. She is a board-certified OB-GYN and a fellow of the American College of Obstetricians and Gynecologists. Dr. Einhorn has decades of experience delivering comprehensive OB-GYN care. So everybody, please join me in giving a warm welcome to Dr. Einhorn. Thank you for joining us today.
Thank you so much. Yeah, when people say decades, I'm like, wow, it's really been decades now.
The word decades really sinks in. Yeah. Well, thank you for bringing your decades of knowledge
Thank
to us.
you.
And I think one, thing I think that is really just important to even lay the foundation and the groundwork of today is talking about medically induced menopause in context, right? And so many of the folks in our program going through medically induced menopause, hormone replacement therapy may not be a safe option for them, which I know is something that we talk about often in terms of menopause management. Do you have a kind of groundwork of like non-hormonal options that are available to help with some of these symptoms?
It is a really good question. And yes, I mean, I actually do get referred a fair number of patients that are currently are breast cancer survivors, are currently undergoing their breast cancer treatment, and they cannot safely take hormone therapy because that would, put their recurrence risk up, and, it's counter productive for their therapy. So, traditionally there have been a lot of different ways we work. I mean, to sound boring and redundant, the lifestyle pillars are so important for patients that can't take hormones, and they should never be underscored. Like, their importance can't be emphasized enough, even for patients that take hormones. So, like, when I have patients that are feeling aches and pains from their aromatase inhibitors, we talk about movement. It's so important. We have like a gym here in the actual practice that helps, that we have personal trainers, and we have yoga, and like all the things that actually can help you feel better in a very non-hormonal way. There are people that I refer to that talk about nutrition, and like nutrition for people, like, well, actually what you do. Nutrition as far as what can make you feel better. Sometimes it's soy, sometimes it's, hot flashes have always traditionally been helped with things like SSRIs and things like this that can help ameliorate symptoms. But really what I've come to lean on a lot in the last couple of years are the new medications that have come out, be called NK3 receptor agonists, which their brand names are called Veoza and Linquet. And really, for my patients that are, whether you're in natural spontaneous menopause or medically or surgically induced menopause, one of the most devastating side effects can be hot flashes and night sweats, because then you're not sleeping, and then the not sleeping can cause the mood disturbance and the cognition problems and the weight gain. And it's kind of like a snowball cascade effect. So these medications are very, very effective in knocking out hot flashes and helping with sleep in a non-hormonal way. And Linquet actually has been studied on breast cancer patients. So they haven't been around forever. They've certainly been studied for a long time. They are FDA approved. We know they're safe. And they're the most effective medication that we've had by far. It kind of like knocks, estrogen, black cohosh, Lexapro, it kind of knocks them all out of the playing field. So to be honest, I really do start there. And my patients have loved them and have been able to get back to the quality of life that they want. So we do a lot of things non-hormonally, starting with knocking out the hot flashes, then sometimes GLPs for weight gain, getting them to feel better so they can start moving again. And life can actually get back to normal, can get back to what you want after a breast cancer diagnosis going through menopause.
That's great. And I'm glad you brought up to those medications, right? I think medicine is always advancing, right? And it's great when we can integrate and start using these options more regularly and understanding the safety. We actually had a member who had asked a question and said she started taking Veoza for her hot flashes. She did mention that. However, one even kind of follow up to that was that this member said their endocrinologist said that there aren't necessarily any treatments for some of these other symptoms like brain fog, acne, hirsutism. Are there any kind of treatments that you would recommend for some of these other maybe hormonal symptoms we're experiencing?
I mean, there are, so because we have to be careful in women that are undergoing, current treatment for breast cancer. And I will say that, it is a little bit, just to back up, the idea of no hormones for breast cancer survivors is nuanced. And it's a little controversial, and it's evolving now in the field. And it's not always a no. And a lot of that depends on what kind of cancer you had. What was it? Was it hormone receptor positive? Was it DCIS? Was your treatment a mastectomy versus a lumpectomy? What, you know what I mean? So it's not always a no, but it is a conversation, and and we educate patients on the nuance and what their actual risks are. But having said that, there definitely are patients that are not candidates for hormone therapy. And all the other symptoms, like you mentioned, the brain fog. So sometimes I have patients, if the brain fog is not cured by helping them get back to sleep with something like Linquet or Veoza, you can work with medications like Adderall. And sometimes a stimulant will actually really help get through some of those cognitive problems, the brain fog, the inability to concentrate, like the acne or anything like that that starts popping around. around, we have spironolactone, hair loss, we have minoxidil. We have a lot of things that can non-hormonally actually really help patients. And even for patients that take hormones, it's never 100% that you get back to. I always tell my patients, your goal is like, let's just see if we can aim for 80, 85% of improvement to the place where you feel like you can be yourself again, you can exercise again. Like my memory is never going to be like when I was in high school or college, and I'm on all the hormones and things like that. But, and the same thing goes for survivors and patients who cannot take hormones. We try to ameliorate the symptoms as best we can. And there are definitely, it's definitely a multimodal approach in patients that have to do the workaround with hormones, but there are absolutely options.
That's great. I think sometimes we just need a little of that kind of reminder, right? That there are
Yeah.
so many options, right?
Yeah, I
It's not
think
just a one
that
and
too.
done.
It's not a one and done. There are other reasons for people to be having brain fog and fatigue and things like that. So we check micronutrients. We make sure that no one's deficient in ferritin or vitamin D, or and kind of replete those as needed. I have a lot of my patients actually, creatine is a supplement that's very well studied and proven to be very safe. And while we use it a lot for like muscle recovery and exercise, I have several patients that feel like it was really what helped them through their brain fog and help with their energy. So like there's definitely options we can explore. Everyone is so different, and we try different things and see which one sticks.
I love that holistic approach, and I think we try to really emphasize that like bigger picture, right? Mind, body as well here at Unite for Her. And one of the questions that we had come in from a member was that their hot flashes are well managed on the medication that they're taking, but ideally they would love to not necessarily have to take a medication, right, for the rest of time. So for something like hot flashes in particular, do you have any thoughts on any like supportive therapies that wouldn't be medication based? They mentioned acupuncture helped for a little bit. Like any thoughts on any of those?
Well, first of all, I don't, for most women, hot flashes do not last forever. So they probably won't need to be on it forever. The average length of time for these perimenopausal symptoms to be bothersome are, it's different actually on an ethnicity basis. So Caucasian women, it's 7 to 10 years, 7 years on average. African American women, about 10 years. Hispanic women Asian women about 5 years, Hispanic women 5 to 7 years. So they don't usually last forever. There are a small subgroup of women who actually will flash into their 70s, and but it won't last forever. And then there are other things prior to having these medications. All we had was like acupuncture and acupressure, and Tai Chi has been shown to help. Meditation has been shown to help. Even cognitive behavioral therapy done for hot flashes actually has been research proven to make a big difference. So, I guess the question is, where do we find these cognitive behavioral therapists that work on hot flashes? Like, I have yet to find one in my area, but they do exist. They do exist.
Yes,
And it is literature proven to work. So
that's
meditation, cognitive behavioral therapy, Tai Chi. So there are things if you want to really be very holistic about it. And I do find that we know also women that tend to, and I know exercise can sometimes be an obstacle, but women that are doing a lot more exercise, a lot more cardiovascular, they're building their muscle, tend to experience more mild symptoms.
okay. And two, I think that even that beginning point of hot flashes aren't necessarily going to last forever, right? I think that's even just so reaffirming in and of itself. And there are so many modalities to potentially trial for support.
Right. The symptoms don't last forever. And one of the most bothersome symptoms that my patients come in actually are the mood symptoms, the anxiety, the depression, the irritability, and the rage. And what the research tells us is that those definitely don't last forever. It's the fluctuations that you experience through perimenopause when they're so bad. And then once you hit a steady, stable state of hormones in menopause, which can take a few years, women's happiness scores tend to rise because the hormones are again at a stable state. So like women in their 60s can feel even happier than when they were in their 30s and 40s.
Nothing's permanent, right? Nothing's permanent.
Life is always in flux.
Yes. I want to backtrack a little bit because I know you said that hormone replacement is a little bit nuanced, right? thinking even too, we have a lot of members in our program who maybe have like non-hormone based cancers, like triple negative breast cancer, for example. Do you have any kind of feedback or guidance there for somebody whose cancer maybe isn't hormonally driven?
So I do have a couple patients in my practice that have had a triple negative breast cancer. And I always do, even one of my patients who was 8 years out from her diagnosis without a recurrence, which actually is in a safer zone for this person. This is like a triple negative cancer is something that tends to recur early on versus much later on in life. So she's even out of that safe window. I did manage to get a hold of her oncologist. And the oncologist really is like, yeah, hormones are a last resort. And we think of them as something that for someone who's triple negative, there really shouldn't be the risk of hormones. And even her oncologist kind of, we both talked about how we understand that nuance. Um, if I always first do go to the non-hormonal methods for these patients, and to be honest, usually, this patient isn't on a non-hormonal method. I did offer her to give her hormones because she's 8, 9 years out. It was triple negative. I would have been okay prescribing them, but I always offer the non-hormonals, and she actually did feel comfortable taking a non-hormonal. Feels good enough. Feels like she got her life back. But it's nuanced because not everyone's risk is the same. If somebody has, been diagnosed in a stage 3 and it's metastatic, their risk of recurrent, like distant recurrence, if you give hormones, especially if they're hormone receptor positive, is high. So, we don't want to ever do harm to a patient. But for someone, for example, that was a DCS patient, stage 0, um, you know, after a mastectomy, their risk is incredibly low. So, these, like my own sister actually is a patient like that. She had DCIS, she had a mastectomy, bilateral mastectomy, and went through menopause pretty bad and is on hormone therapy now. Not, I mean, I of course gave her my opinion, but this is being prescribed by her own gynecologist. So it's a nuanced conversation that, it's hard because it still is a contraindication in the prescribing guidelines. You know what I mean? But I do think survivors deserve better. I think that I'm really happy that we're starting to look into the literature more and starting to do more research on it. There's current studies now on a hormone therapy called Duave, which is actually being studied now in DCIS patients. It's a combination of estrogen and then a SERM, a selective estrogen receptor modulator called beta-doxyphene. And they're starting patients on it from the time of their diagnosis till the time of their lumpectomy or surgery. And they're measuring Ki-67 tumor markers, and it's showing like decreasing levels of this tumor marker. So it's being looked at now as even a preventative strategy. So there are options, and these are like perfect options for someone whose symptoms aren't controlled non-hormonally, that with shared decision making and education, it's not something that is a blanket no for me.
And I think it's so interesting to hear about all things up and coming. And I also like too that you mentioned the shared decision making. And I think too, even hearing you mention like collaborative care as well too, because I think many of our patients and our members are thinking, well, I have to specifically be talking to this one person, but it also could be a collaboration of providers who are helping you to make the best decision. And then you're making the right decision for you at the end of the day.
I do think I think doctors have the right to decline therapies that they feel would be harming the patient. But I also feel like patients have the right to be educated and be able to make those decisions for themselves. Like I have a patient who's a breast cancer survivor, and her oncologist has told her no on vaginal estrogen. And I personally don't agree with that. And I gave her my opinion and showed her the literature that I feel supports its safety, and spoke with her oncologist, who our oncologist agreed that it wouldn't, like, if the other things don't work, it is okay. But, and it took my patient a little while to come to that. Like, she didn't want to use it at first. And we worked with other non-hormonal methods like vaginal moisturizers that contain hyaluronic acid and things like that. But eventually they weren't cutting it. And she's unable to like have a sex life with her husband because of pain and dryness. And her marriage and her sex life are very important to her. And this was like when she came back to see me, she's like, you know what? I've tried everything. It's not working. I would have given her vaginal estrogen from the start, but I absolutely respected her. Like I respect her oncologist. I respect her. And, but when she finally came to me, she was ready because she felt like this was a time when something that was really important to her and her family was in jeopardy. And she did start taking the vaginal estrogen and at very low doses, it's absolutely corrected the problem. And I do think that pretty much everyone is a candidate for it, really, no matter what kind of breast cancer is happening. It's something that's safe and we know is not absorbed into the bloodstream in any kind of detectable amount. So, the I talk to my patients a lot about the downstream consequences of surgical or medical menopause, abrupt cessation of having estrogen in your body, and what that could do for your all over your body, including your vagina, including your sex life, including your relationship, and how they can best prepare for that so that it doesn't hit them as a surprise and they don't kind of come for help too late if it hasn't already been brought to their attention.
And I feel like that is a great segue too into a question that I know we hear oftentimes is about vaginal dryness or pain with intercourse. And it sounds like what you're saying is for most people, low dose vaginal estrogen is potentially a supportive technique. But what are some of maybe the other techniques as well too to help that as well?
Right. So there are like I have a full stock in my closet of what's called vaginal moisturizers. They're different than lubrication. Lubrication is a must. It's a must. And I like the brands Uberlube. I like Good Clean Love. And the lubrication though sometimes is not enough. And lubrication is different than a vaginal moisturizer. A vaginal moisturizer is something that you don't just use before sex. You don't use it for sex. That's a lubrication. You use that during sex, right before sex. But a vaginal moisturizer is something that you use, try to use it about 3 times a week. And it contains something called hyaluronic acid in it, which actually helps keep the water inside the cells. So it keeps the tissue a little bit more plump, a little bit higher water content, and that can really help if patients are compliant with its use. And then I also talk to my patients about that might not be enough too. And, sometimes I work with my patients with like vaginal trainers, which are, I mean, I have some in my back thing if you guys want to see them, but like, they're really like, serial dilators that start from as small as my finger to like bigger than you want to see. You know what I mean? So some of the bigger ones scare my patients. And I always tell my patient, like, this is something that without any fear of being hurt, you can use in the privacy of your own home with or without masturbation, because we know arousal, a lot of different, physiologic changes happen in the vagina to help allow for something to be in the vagina. And you use these dilators on yourself, and you're not going to hurt yourself with lubrication. And you start small. And when the small one's not hurting you anymore, you can move up to, the next size up until you're accommodating something that is like a little bit, maybe a little bit bigger than your partner. And then so at least in the back of your mind that you can that can fit in your vagina, you know what I mean, without pain. And then sometimes the second step is learning how to use that with your partner. Maybe he's going to be inserting it with your communication and cues about how fast, how slow, how deep, things like that. And until finally you get to a point where you're at the point where you actually can have sex. And then I say, like, that should be in a position of you being in control, controlling depth and rate of penetration. And then gradually, as a stepwise process that can take many months sometimes, you know that you're going to feel comfortable with communication back and forth, that you'll be able to do it in any position and it won't without pain or apprehension. But communication is key. Using moisturizers, using lubrication, sometimes having to use toys and dilators, 100%, it can happen.
Yeah. And I think the
Like the
communication aspect so important.
So important. There has to be trust there. You have to know that your partner is listening to you as far as like, taking your cues, and most partners are very sensitive to that. They don't want to hurt their wives. They don't want to cause any pain. But if there's no communication there, like I do have patients that literally through sex just like are like white knuckling it and not saying anything, and their husbands don't even know. And I really do encourage them to, you know, have that communication, because it doesn't have to hurt. You can get to a place where it doesn't hurt. And that does usually require a pause in the sexual activity, because it needs work and it needs communication. And I'm sure their partners would not be interested in hurting them. And there's many other things that can be done outside of actual penetration as well.
Sure. Sure. And like you said, it's maybe a process that takes a little bit of time, right? But I think it's one of those things where ultimately, through that time and that process, it's so worthwhile in the end.
If it is important to you, it's worthwhile. If your relationship and is important and the sex life is a part of that relationship for you, it is. If it's not important to you and you don't miss it and your husband doesn't miss it and it's not causing a problem in your relationship, then it really isn't a problem. I certainly have patients through the years that are like, we're really good. We cuddle, we snuggle, we're best friends. We're both on the same page. It's not a problem. I don't need to bother you about it. You don't need to bother with it. You know, I do think that there's more to like what we call now the genitourinary syndrome of menopause just than being able to have non-painful sex. I think you also have to start thinking about what happens with the urinary tract. Like the vaginal tissue surrounds the urethra, which is the opening to get to the bladder. And when the tissue thins there so much in menopause, you can predispose yourself to having UTIs. And UTIs in your 70s and 80s can be life-threatening. They can result in urosepsis and death. And almost everyone's known someone that may have died or have been hospitalized for urosepsis from bladder infection. So really the vaginal estrogen is the only thing that takes care of that.
Okay. Well, that's good context, I think, for everyone to just keep in mind.
Yeah.
Switching gears just a little bit is, I think, some of these longer term considerations we're thinking about when we're thinking about menopause as a whole, but specifically medically induced menopause. And we have a lot of conversations on our nutrition team about calcium and bone health, right? What do you recommend to support bone density, given that medically induced menopause puts patients at higher risk for osteoporosis?
I mean, I think patients need to be getting these bone density scans done early. Like, I have seen so many patients that have undergone a cancer diagnosis and undergone treatment and never been on estrogen because, estrogen is really what helps preserve the bone in a very healthy way. And losing that estrogen early, especially younger than 40 or 45, really puts them at huge risk for not only just osteoporosis, but cardiovascular disease and dementia and early death. So just in speaking in the realm of bones, they need that bone density scan done early so we know where we're starting and they need it repeated, okay? Because that changes. Like just because if you get a baseline 2 years later of estrogen deprivation, you can be in osteopenia, which is the precursor. You can have osteoporosis. So the best preventative strategies, if you're not using estrogen, absolutely have to do with weight loading, axial weight loading. So I have a patient that absolutely reversed her osteopenia just by the weight training that she did alone. Now she's hitting it hard. Like she's really doing what we prescribe. She's doing her weightlifting 2 to 3 times a week and she's challenging herself. This usually means that you have to be, lifting weights that are heavy enough that by 8 or 9 reps, you're not getting that ninth one up. I recommend most of my patients are doing this initially under the supervision of a trainer who's experienced. Doing it in some very supervised class, not CrossFit or things like this. But like the axial loading really builds bone. Actually, walking downhill builds a lot of bone.
Wow.
Walking uphill is your cardiovascular. Walking downhill builds bone because you're constantly having that impact. So they have studied that. Walking downhill is actually very, very beneficial. So, but really the axial weight loading is key. And then yeah, making sure that you're having making sure you're having adequate calcium in your diet. And I always do emphasize dietary sources first. So like Greek yogurt is amazing. Cottage cheese is amazing. There's fortified cereals and fortified orange juice. So there are ways to get a lot of calcium into your system every day. And I use supplements as the last resort. Taking a calcium pill is not as good as getting it through your food source. And it's not that hard to get like the, recommended daily allowance through your food source. And then making sure you have your vitamin D. All these things really do really help. And then, if osteoporosis does develop, because there's only so far that will go fighting genetics, which is really like the biggest proponent. Like if they have a family history, they really need that early testing. Then there are medications at that point that are non-hormonal that will treat your osteoporosis. And they're good medicines. Some are complicated, but there are a lot of bone building medications that are working very well now.
I know you mentioned too at the start, osteoporosis and bone density is just one piece of the equation. You were talking about like cardiovascular and dementia. For things like that, and maybe even starting with cardiovascular, what types of screenings are you recommending there? Are you thinking somebody needs to work with a cardiologist in addition to their other providers?
I think I refer more patients to the cardiologist than I do any other subspecialty because of my practice being unique in that I'm seeing really primarily women in midlife. Like the only younger patients I see are my patients' daughters. And but like, everyone in perimenopause, like our cardiovascular risk is always lower than that of a man through our whole lives. But then what changes through perimenopause and menopause when our estrogen levels drop is that suddenly our risk now all of a sudden equals that of a man. And that is that estrogen has effects on our lipid profile. And so I would say probably 70% of my patients have an abnormal lipid panel when they never had it before. Okay. There's a huge genetic component to it. I'm one of them. I thought I could like out diet it, out nutrition it, out exercise it. Over the last few years, it only went up. So I myself saw a cardiologist and went on a statin because that is the number one way to reduce cardiovascular risk. I'm going to just put a little like pin on that saying, obviously we're talking about lifestyle, cardiovascular, diet, healthy, maintaining a healthy weight, things like that. But provided you're doing all that, like I'm not trying to lose more weight. I am exercising. It's just, it's unfortunate that there's a huge stigma against statins these days for reasons that are, I think, mostly unfounded. There's a side effect profile to statin. Sometimes you get muscle aches and things like that, but there's always an option that won't cause those side effects. And the analogy that I love about heart disease is that, it's the number one killer of women. It's not cancer, it's actually heart disease. And, it's like we want to stop the calcification of our arteries. And like this, it's like the snow is the snow in the air is the cholesterol. The fluffy snow on the ground is the accumulation, the soft plaques that accumulate on our arteries. And then those soft plaques harden into calcified plaques, which cause coronary artery disease and heart attacks and strokes. And that's the ice underneath the fluffy snow. And the only way to stop that from happening is to stop the snow in the air, which is the statin. So I send all of my patients that have abnormal lipid profiles to get a calcium score. Sometimes they need what's called a CT angiogram to see soft plaques. And if they have any abnormalities, I send them to a cardiologist, and my cardiologist has to talk with them about statins, about their risk. And and that is preventative. Like cardiovascular disease is highly preventable. So, it's a special knife in my heart when patients tell me I would never go on a statin, but their cholesterol is sky high.
Yeah, I
So yes,
really
cardiology.
appreciate the analogy too. I think that
I
that's
love the
helpful to
analogy.
understand it a lot better.
There's someone I watch on Instagram who's a preventative cardiologist that has so many great analogies, and I love watching him.
Yeah, sometimes you just need that for it to click. So I think that that's good perspective, right, on cardiovascular health. And we can do so much, but also there's maybe so much benefit to a statin potentially as well, too.
There really is. I mean, it's a healthy lifestyle, but like we know that only 15% of our cholesterol actually is influenced by our diet. The other 85% we make, and it's genetic. Both my parents had high cholesterol. I wasn't surprised when I ended up needing to go on a statin just like they both were. And I was actually like, well, it's always a lot of my patients go through a hard time when, they come in healthy and it's a time when they've been able to be without medication their entire life. And now suddenly they're being introduced hormone therapy or a statin, or, this is when we start having health problems where they need to go on an osteoporosis medication. And it's a big blow, but eventually, for me, I was like, well, I'm really glad statins exist because now I can try to, ameliorate that one risk factor. Like maybe I'll die of Alzheimer's. I'm not going to die of heart disease, sounds like crazy, but
Right. Preventative where, preventative can be, I think is
um,
so important.
yeah, the major areas that women are not getting preventative enough care is cardiovascular disease and osteoporosis. I mean, the guidelines call for the first bone density scan to be done at 65 years old. And we know at that time, 37% of women are already going to have osteoporosis. So what are we doing? Why are we not like if women knew earlier on 15 years ago that they already have osteopenia, of course they're going to want to jump on that bandwagon. They're going to get to exercising. They're going to, potentially go on an estrogen patch or just make sure they're at least getting their adequate calcium.
Right? Taking those steps.
Yeah.
We had a question come in from the audience that I thought was really interesting about surgical menopause. And do you have any insight on surgical menopause causing like ligament changes? And if so, what can be supportive for some of that pain and that discomfort that's associated potentially with that surgical menopause and that change?
I mean, I do think surgical menopause, it definitely has that abrupt cessation of, you're going to go through menopause a lot. It, it's going to be a lot more difficult. A lot, the abruptness of just like all of a sudden your body is devoid of estrogen. It's not like the, it's not like the natural spontaneous process that happens to women that go through it naturally, right? So there is what we call now musculoskeletal syndrome of menopause. This is like muscle aches and tendinopathies and just like joint aches and pains. And it can be very severe. So, there it is a problem. And really for women that can't take the hormones, it's movement. It really is movement. It's anti-inflammatory medication, it's NSAIDs, it's movement. It's getting in a pool. It's warm baths. It's not what I wish it was. You know what I mean? It's not what I wish it was.
It's tough, I'm sure, navigating the host and horde of symptoms, and then also to be just like physically so uncomfortable at the same time, too. So, it's definitely a big shift, like you said, very, very abrupt.
Surgical menopause, I think, is probably the toughest. Second to aromatase inhibitors. When I know a patient is going to go through surgical menopause early, it's different if a woman is already in her 50s. Ovarian estrogen production is already waning, if not completely, minimal to gone at that point. But for women that have to undergo, like well, first of all, for women that undergo oophorectomy, which means your ovaries getting removed and they're younger than 40, generally whatever they're, they are candidates for hormone therapy. The rules don't apply to them generally. Like they do need repletion because what they're facing as far as increased morbidity, mortality is, those risks potentially outweigh the benefits. So those patients are in a different category. But women who have surgical menopause in their late 40s and into their 50s, they can go through a lot of joint aches and pains. It does go away, but it's really supportive care at that time.
And I think, your practice, right? And like practices similar are a great example of ways that people can really advocate for supportive care. And I think a great kind of question to wrap on that, I know I hear a lot from our members is that maybe they feel like their concerns about menopause and its symptoms aren't necessarily being heard, or maybe their care team isn't up to date on the latest symptom manage or medication options. What
Mhm.
steps would you recommend for someone in that scenario who can advocate for themselves for supportive care?
I definitely think that it would behoove them to find a menopause specialist. And if there's not one in their area, there are a lot that do telemedicine. If you go to the menopause.org website, you can find a list of providers. If you go to Mary Claire Haver's pause.com website, there's also a patient generated list of providers. So these are not Menopause Society certified providers necessarily, but they're at least patients recommended that they've been sympathetic of menopause. I think that what was I just going to say? Now my perimenopause like but there are even like if you follow people on Instagram like Dr. Corinne Min, who is herself a breast cancer survivor and really dedicates most of her platform towards survivorship care and advocacy. Even small things, just like vaginal estrogen, can make a huge difference. And she does provide all like the literature for patients that are meeting their doctors and, really coming up upon obstacles to getting these medications. There's literature on her platform that you can print out and bring to your doctor. Hopefully that's well received. But it's not impossible to find a menopause provider because there are a lot even online if there's not one in your area. And a lot of them are insurance based as well.
I love that you mentioned Dr. Corinne Men because we actually have been in touch with her and she will be speaking for us in October. So
Oh,
a little bit of
I
a
mean,
teaser for
amazing.
everybody that's coming up.
Yeah, she's a wealth of knowledge, amazing. She's kind of like leading this leading this push for survivors to be able to get what they really want and need and what they rightfully deserve.
Yeah. Well, any parting words of wisdom, Dr. Einhorn, before we wrap up today? Any last supports or anything you're like, we didn't even touch on this, but I wanted to make sure I mentioned it?
No, I mean honestly, I feel like that's always the question where I draw a blank because because it's like so much that it doesn't ever pop into my head. But really, I do think it's important for women to be aware that there are these for breast cancer survivors, or any survivor where you're really going through which forces you into a menopause. Just be aware that there really are those treatments that are very effective. And I have had a lot of success in this practice being able to get women to a point where they feel good again. So bring these to your provider if they don't, if they're not always aware of them. Like I have them back here, Bioza like, and make sure that you can, like, once you start feeling a lot better, then you can really get into the movement. The movement I found has been key here. I mean, for like talk about like the muscle aches and pains, it's not easy at first to get it done, but once you start and you get into that regular routine with consistency, you start feeling a lot better.
I always like to say when I talk to people about movement is it like sounds counterintuitive at first, right? You're fatigued or you're in pain, and so you don't want to start movement because you're fatigued or in pain, but ultimately it can be a huge supporter overall.
I mean, they say movement is medicine, and it's true in so many different ways.
Yeah. Well, thank you so much for all of your time and your wisdom today. I mean, I know I learned a ton, and I know our audience, I'm sure, has very much greatly appreciated all of your feedback and all of your guidance. And where can people find you or get in touch with you if they want to connect with you as well?
Well, I've been honored that you guys had me. This was a lot of fun. I do a lot of my own Instagram, giving out some menopause information and guidance, and that is just at Kim Einhorn MD. So it's KIMEINHORN MD, and that's on Instagram. I'm on Facebook, same. My practice is the MP Collective. I'm based in Bryn Mawr, outside of Philadelphia, and I can be reached here. I'm the MPcollective.com.
I love it. Thank you. And we will share all of that out as well, links so that people can contact you. But thank you again for taking some time with us today. And as we wrap up, I, of course, want to take another moment to thank our wonderful sponsors because our virtual education events would not be possible without them. West, Merck, and Novartis, with support from gold sponsors Pfizer and Daiichi Sankyo, and supporting sponsor GSK. And we hope everybody will join us next week on Wednesday, the 17th at 5 p.m. Eastern Time for our Summer Beauty Celebration. You can register for that at UFH Connect. And if you didn't get to watch all of the segment today, maybe you hopped in the last 5 minutes, our recording will be available at UFH Connect too. But otherwise, I hope everybody has a great day. Thank you, Dr. Einhorn.
Thank you.
And we will see everybody next time.
Take care.
Bye, everyone.